Hello, and welcome to the symplr Education Series webcast, partnered with Greenly. Today's webcast is titled Payer Credentialing and Provider Enrollment, with speaker Amy Niehaus. At the end of this session, we will have time for a formal Q&A, but feel free at any point to ask questions as they come to mind via the chat box located on the right side of your screen. You will also be able to download the archive of today's webcast and its slides at symplr.com soon, and will receive download information in an email. Again, welcome to the Cactus from symplr webcast along with Greenly. Next, I would like to introduce today's speaker. Today, we have Ms. Amy as our guest speaker. She is a consultant for the Greenly company. She brings more than 25 years of credentialing and privileging experience to her work with medical staff leaders and medical service professionals. She has worked in multiple healthcare environments throughout her career, including acute care hospitals and health systems, credentials verification organizations, and managed health and care plans, and has also been certified by NAMS as a CPMSM since 1992 and a CPCS since 2002. I'm sure many of you know her, and I'd love to turn it over to her now.
Thank you very much, Callie, and good morning or good afternoon to all of you that are attending, wherever you may be. Thank you for joining us today. We are going to be talking about payer credentialing and provider enrollment, and I use the phrase two sides of the same coin because not only are both sides of the coin of the credentialing process involved, but no pun intended, but there's also money involved, right? Payer credentialing and provider enrollment are critical to the revenue for physicians and organizational success. So understanding what the health plan requirements are can really help the organization develop an efficient enrollment process for the employed healthcare practitioners. And these are the objectives that we want to accomplish today. We're going to talk about the requirements of payers in the credentialing world, possibly look at ways how you can integrate your enrollment with your credentialing process, and then also taking it to the next step and achieving delegated credentialing to further to obtain further efficiencies with that process. So let's just start off with some definitions. So what is payer credentialing? So this side of the coin is really that process that the payers do to collect and verify information and evaluate an applicant's conduct and competency to participate in their particular networks. The other side of the coin is provider enrollment, and that is the process of collecting the information that the payers need and submitting it to them in a way that they can readily process it, allowing your practitioners to be enrolled and then also to bill for those services. And you'll also hear this termed as payer enrollment. We'll talk a little bit further, but there's a lot of terminology being interchanged in this space. But the one thing that I don't like to call it is credentialing, because they are two very different sides of the coin, the enrollment process and the credentialing process itself. And we'll talk a little bit more about those differences. So why do we need to understand those differences? Why is it important to understand payer credentialing and provider enrollment? Well, these numbers continue to grow of these employed practitioners in our healthcare systems and hospitals. And there's a lot of studies out there that show that this continues to rise. Now, the numbers will vary depending on the region and the types of facilities and that kind of thing, but overall everyone tends to agree that the rise of healthcare organizations employing practitioners will continue. And whether you work for a profit or not-for-profit organization, at the end of the day, you have to have more revenue coming in the door than expenses being paid out in order for the organization to be successful and meet the obligations to both the patients, the practitioners, as well as the communities that we serve. And provider enrollment is a very time-consuming process. There's a lot of paperwork that's being collected and being submitted to all the different payers, tracking where that paperwork is in their process, following up on a regular basis until such time that the employed practitioner is approved and effective with the plan. And then you have to repeat that process for every plan that you contract with, and that can range anywhere from 10 to 20 or even more than 30 plus, depending on where you're located. And sometimes this delay is going to significantly impact the ability to see the patients. The practitioner is waiting to be credentialed by the payers and sometimes can't see patients at all, or if you are seeing patients, then it may be difficult to get paid for that service. They typically don't start working until they are enrolled, but that delays payment, and sometimes the organization doesn't get paid at all, has to write that payment off, or even if you have to hold claims, it's delaying that revenue door. And that means those funds aren't available to support other commitments or services within your organization. And this doesn't always necessarily impact the employed practitioner themselves. They may have salary guarantees and may be receiving their income, but it's the healthcare employer that may be losing that revenue each day that the practitioner is not seeing patients. So definitely a lot of revenue challenges all around with the process. So how can medical services professionals play a role in achieving more efficiency with these different processes? Well, that's basically what we are going to talk about today. So I first want to start off with just defining what payers are. And basically, they are the entities that finance or reimburse the cost of health services. And we as individuals will typically pay for some portion of our healthcare costs through premiums and co-pays and things of that nature. But for the purposes of this presentation, we are going to just refer to the payer as being those entities that are involved, and we'll talk a bit about those. So there are a lot of different payers out there that we work with. There are the federal and the state payers, such as Medicare, Medicaid. You have TRICARE or TriWest for military. And you have the commercial payers, which is going to be the focus of this presentation. Those are the ones that are more commonly known to a lot of us. We may be covered by them ourselves, but they are the health plans, or the acronym Managed Care Organization is typically used. But they could be national payers like Aetna, the Blue Cross Blue Shield plans, United. There are also a lot of regional and state health plans and networks that are out there that many of us are involved with and need to enroll our practitioners with. And workers' compensation is also a type of payer that I wanted to reference that may also be part of your organization's enrollment process. But as I said, today we're really going to focus on those commercial payers. And what is credentialing exactly? It's a process that ensures that the practitioners meet the requirements of the organization. They're qualified, they have the right education, the right training, the right experience to provide services to members. And that credentialing is performed in a lot of different organizations in our healthcare environment. Hospitals are doing it, CBOs are involved, medical societies, surgery centers, IPAs, PHOs. There's a lot of different entities involved, and the payers are doing that process as well. And you may also refer to payer credentialing, you may hear it as managed care credentialing, but it is a credentialing process that we're going to get into some more detail on that the payers are performing. So why are the payers actually credentialing? There's a lot of reasons involved. One is we want to make sure that a practitioner is who they say they are and is qualified to do what they want to do. So it's really about making sure that a practitioner has that legal authority to provide care. There are also some precedent-setting legal cases that involve managed care plans that have occurred primarily in the 80s, but they still occur today. But there were two key cases that occurred. One was Boyd versus Albert Einstein Medical Center, and another one was McClellan versus the HMO of Pennsylvania. And both of those held that managed care organizations or health plans are held liable for the actions of their practitioners. If you're not familiar with those cases, I would recommend that you look those up. They are very interesting cases and really have dictated a lot of what payers do today. We also have different accrediting and regulatory bodies that have requirements on what payers do in terms of credentialing processes. And as all organizations, there may be internal policies and procedures and other requirements that need to be followed. For the accrediting bodies, there are two that payers will typically follow. One is NCQA, that is the National Committee for Quality Assurance, and that is the primary accreditor that I'll be focusing on today during the presentation. But under NCQA, under the credentialing standards that are required by health plans, there are some other elements that NCQA dictates to the plans as well. And one is HEDIS, which is the Healthcare Effectiveness Data and Information Set, which is basically a set of measures that health plans will track and submit data to NCQA regarding their services that they provide to members. Examples include immunization rates, well child visits, cancer screenings, and even board certification rates for the physicians that are in their networks. CAHPS is a survey process. It's the consumer assessment of healthcare providers and systems. Just more acronyms that we have to know in our environments. But CAHPS surveys are basically surveys sent to consumers, and you may have received one in your capacity as a patient in sometime in the past. But that survey is really just trying to obtain information about your experience that you had with your healthcare provider, with that office, with the services you received. And together, the HEDIS data and the CAHPS data is submitted to NCQA. CAHPS data is always being collected, and the HEDIS data has to be submitted on an annual basis. And NCQA then uses this information in addition to its regular accreditation process and survey of a health plan to determine what that health plan's ongoing accreditation status is going to be. If the HEDIS and CAHPS scores fall way below what is expected, it can impact a payer's accreditation status. And then there are also the federal and state requirements that payers have to follow. CMS comes into play if they are providing Medicare Advantage or managed Medicaid plans. States have their own departments of insurance that may have regulations that payers have to follow. There's the Healthcare Quality Improvement Act, which we're all familiar with, as well as HIPAA and the Affordable Care Act, which has impacted the payers. So who exactly has to be credentialed? Under NCQA, practitioners, and that would include physicians and non-physicians, that have an independent relationship have to undergo a formal credentialing process. And what I've listed here are the common types of practitioners that would be credentialed by a payer: your physicians, your oral surgeons if they are providing benefits under a medical program, not a dental network, but a medical network, the chiropractors, podiatrists, the various behavioral health practitioners, your psychologists, your social workers, your counselors. And then I have rental network practitioners, and that is asterisk because there are very specific criteria that have to be met for a payer to have to credential them, and typically they only have to be credentialed if they're going to be listed in a directory, which most often does not happen. And a rental network is basically when a health plan is wanting to expand their coverage in a certain area, they may contract with another plan, another organization, and utilize their practitioners to help provide that coverage for their members. It's not something that you typically see. And if there are other practitioners in the payer's scope that they want to include and want to list in a directory, those would be expected to be credentialed as well. And that's what basically defines an independent relationship. When a payer is selecting and directing members to see a specific practitioner or a group of practitioners that they're going to put in a directory and encourage them to see those in terms of the types of benefits that they would receive as a member. One of the elements that are elements of practitioners that are not required to be credentialed are those facility-based practitioners, your emergency room physicians, your radiologists, anesthesiologists, pathologists. Those are typically credentialed in a hospital setting, but for payers, they are not included for the most part because, again, they're not going to be typically listed in a directory, and members usually do not go and select their own anesthesiologist or pathologist. It is based on the facility they go to that would dictate what practitioner in those specialties they would be taking care of them. This is kind of a very high level. I mean, there's a lot of detail that goes on in the credentialing process for a payer, but this is just kind of a high level structure to give you an idea of what it looks like. So a practitioner would request network participation of either might come directly to credentialing, but most often it's going to go to contracting or a network management or provider relations department. Because there's the contracting involved. So a lot of times that's going to come in through an area other than credentialing. And if once it's determined whether credentialing is required, then that will determine the next step in their process. Based on the type of practitioner and the kind of contract they're having with the payer, then a decision is made whether credentialing would be required. If not, then it would just stay within the contracting or network management area where they would follow their own contracting process. If credentialing is required, then that information would flow over to credentialing. From that area, an application would be obtained. The contract would also be coming in, and that would go back over to contracting. I'm missing my little arrow there to the left. But the credentialing process would follow through. They would process that application, verify the credentials based on the NCQA requirements as well as their internal policies and procedures. And it would then go to either the medical director or the credentials committee for review. And we'll talk more about what that process looks like when it can be the medical director and when it needs to be the committee. And once a decision is made, the applicant is notified, as well as the internal departments of the payers. The contracting and network management department needs to know when credentialing has been finalized. And if they are approved and then subsequently contracted, then that practitioner would then be listed in the member directory. So I want to walk through the steps of the credentialing process in a little more detail. As I mentioned before, the application does come in through usually another area than credentialing, but most often a payer is going to use the CAQH form, but there may also be an organization form that's used or a state-specific form. That application, again, is reviewed for completeness to make sure all the supporting documents have been received, all the information that's requested on the application is complete, and before proceeding on with the rest of the process, which would be the primary or approved source verifications. Not everything is necessarily primary source verified. NCQA does have some elements that can be approved through one of their sources. And we'll talk a little bit more about that. But the review process of whether or not there's any red flags, that's the common term we use in credentialing to determine whether there's any issues of concern that may need to be brought to someone's attention within the organization. So once all of that process has been completed, that's where it can branch off into two different areas. The medical director may review it based on the credentialing committee giving that individual the responsibility and authority to do so. And any application that is considered a clean application, meaning it meets all of the organization's criteria as a clean application, can go through the medical director process, which is usually a much faster process. The medical director can review those on a daily or weekly basis and approve them if they do meet that criteria. And if an application does have red flags and doesn't meet the organization's criteria as a clean application, then it does have to proceed through the credentialing committee and get reviewed at that level. And the decision would be made to either approve, deny, or pen that application. Possibly more information might be needed. And under NCQA, the applicant then has to be notified of the final decision within 60 calendar days. and that is typically not a problem to meet, especially if an applicant has been approved. Sometimes if there's been a denial, there may be some additional involvement with legal counsel to make sure the denial letter is worded appropriately, that kind of thing. But NCQA does give a pretty lengthy time frame to notify the candidate that they have been approved or denied. So under NCQA, these are the verification elements that have to be verified. Initial credentialing and recredentialing. And they're basically the same. The two differences at recredentialing is that you don't have to verify education and training, just like in most organizations, unless something new has occurred. And work history does not have to be verified either. But these are the standard elements of making sure there's a complete application that meets various requirements in terms of disclosure questions and other information, that the applicant has attested to the correctness and completeness of the information that they've submitted, primary source verifying license, board certification, the DEA or CDS, the state DEA, can be verified through a copy of that certificate, or it can be primary source verified. The work history is not verified in the manner in which many hospitals verify that work history. Work history under NCQA is basically evaluating the work history provided on the CV or the application and making sure that there are no gaps in that history that meet the organization's requirements. NCQA allows 6 months as the largest gap that you could have. Most organizations go shorter than that, but at a minimum at 6 months, if there's a gap, then that has to be explained verbally by the applicant, and if it's more than a year, it needs to be explained in writing. Most payers will ask for it to be explained in writing either way, but under NCQA you do have the option if it's a shorter gap. And verifying professional liability history, license sanctions, and Medicare and Medicaid sanctions. There are different sources for all of those elements. Most often you'll see the NPDB being used for many of those elements, but of course going directly to the source as well. The time frames for these verification elements are a little different based on the element. The application and attestation and the work history have to be, when we say verify, they just have to be collected and received within 365 days of the decision. That seems like quite a long time, but they just want to make sure that you're not using applications as a payer that are really old. The other elements, the license, the malpractice history, board cert, those things need to be verified within 180 days of the credentialing decision. And DEA, CDS, and education and training, there isn't a time limit as long as it's done prior to the decision, because those are more static elements, so they could have been verified a longer time ago, especially if the applicant had been part of your network in the past, or it may be information that you're collecting from a credentials verification organization or something like that. But the payer has a little more leeway there, because once it's verified and as long as it's done before the decision is made, then that would be acceptable. And the license and DEA have to be current at the time of that decision, regardless of the time frame involved with verifying it. When NCQA looks at a payer's compliance with their time frames, they base it on the date of either the medical director or the credentialing committee approval date, depending on whether it was a clean file or not. And that decision, again, has to be within the time frames dictated by NCQA. So all of those different elements have to be within the 180 or 365 days of the decision. So as an example, if the decision was made by the medical director on May 25th of 2016, then that license verification has to have been verified sometime between November 27th of and May 25th. And if a verification would happen to go beyond that, the plan just has to re-verify it prior to that decision occurring. So there's always that last double check before it goes for decision to make sure everything is within the time frame. There used to be a thought that the 180 days meant the plans had 180 days to process a file, but for the most part, that is really not about the full length of the time. It's just the time frame from when the verifications have to be obtained. So a process could go much shorter, a process could go longer, depending on the plan and the completeness of the application and the information being verified. But everything just has to be within those time frames at the time the decision is made. And it's really just to make sure that decisions are being made with information that's just not incredibly old. Making sure that there's as current of information available to the medical director or the credentialing committee as possible. And with our technology today, a lot of times that credentialing process can take much less time to complete than these time frames that NCQA allows, because so much of it is now available electronically. The recredentialing process under NCQA is required every 3 years. That's very different from a hospital environment where it's typically 2. And that recredentialing process is, again, very similar to initial credentialing. The initial verification timeframes that we talked through earlier are the same ones that apply at recredentialing in terms of the 180 or 365. And the compliance with the recredentialing 3-year cycle is measured from month year to month year. So in the example, making the decision on May 25th of 2016 gives the plan until May 30th of 2019 to make the recredentialing decision. So it looks like it's more than 3 years, and technically it is, but as long as it's occurring within the same month, 3 years later, it would still be considered compliant. Hospital environment, not so much, but under NCQA it's just month year to month year. Once an applicant has been initially credentialed, and in between that point of time and when they become recredentialed and ongoing into the future, the payer has to monitor for various things in an ongoing manner, and that's continuing to look at Medicare and Medicaid sanctions, continuing to look for license sanctions or limitations for those practitioners. And they also have to monitor for complaints that may be coming in, practitioner-specific complaints that members may file with the payer. Or they can also be monitoring for adverse events. An adverse event is when an injury occurs to a member while they're receiving health care services from a practitioner. And the organization, the health plan, must have processes in place that they would look for those types of things within 30 calendar days of information being released. So OIG is very timely in releasing a report of sanctioned providers every month. So when that report comes out, the plan has 30 days to review it and determine if any of their practitioners are listed. License boards can typically be very consistent as well. Complaints and adverse events, those are more internal to the organization, so processes have to be developed to be able to monitor for that as well. If an organization or a source does not timely produce information on a regular basis, then the health plan has to at least look for that every 6 months to see if there's any information out there. And with the continuous query that NPDB offers, more and more organizations are going to that source, and because that does meet the intent of the NCQA standards for the Medicare Medicaid sanctions and the license sanctions. Again, those are the external elements that have to be monitored. And with the greatly reduced price that just went into effect the beginning of the month, it's really hard not to take advantage of that ongoing process and have them do the work for you. And one of the final standards under credentialing for NCQA is that there has to be an appeal process. So if an action is taken, an adverse action is taken against a practitioner by the payer, then they do have to offer a formal appeal process if things are related to quality of care or service issues. NCQA's appeal process requirements are very similar to the Healthcare Quality Improvement Act. although state regulations may come into play if there are some differences. So the payers have to be aware of their state requirements, and if they're in multiple states, then that can get a little tricky if there are variations in what the states are requiring, that they just need to make sure they're following the strictest requirement to be in compliance with everyone. I want to just take a minute to go through some of the differences between the payer credentialing process and a healthcare organization, and typically a hospital, just to clarify some of the areas that are very distinct between the two organizations. So under education and training, the health plan only has to verify the highest level of education and training. If they're board certified, then that would be considered the highest level. They don't have to verify everything like a hospital typically does. They want to make sure that they have verified the medical school and the residency and fellowship and board certification, whereas health plans have the option to only do the board certification if that's in play. Otherwise, they would need to do the residency. Peer references, those don't come into play for a health plan. But hospitals are required to obtain those at that initial appointment and privileging process to use that information in determining competence. The malpractice claims history, health plans, NCQA dictates that you have to verify at least the past 5 years. For a hospital, it's what your policy says. Maybe it says 5 years, maybe it says 10, maybe it says you go back to the beginning of training. It's whatever the policy is defining. Under privileging, again, privileging does not come into play for a health plan. But for healthcare organizations, again, that's dependent on the type of practitioner and their specialty and the way they practice. They may be granting membership only, so privileging does not necessarily apply to everyone. So it's just going to be applicable to the type of practitioner and what the organization requires. The time frames we talked about at health plans under NCQA have a lot of time frames they have to adhere to, whether it's for the verification process or the notification process. For a hospital, it's going to be based on their policies. Whatever they're defining as their time frames is what they need to adhere to. And reappointment, recredentialing, there's a difference right there in terminology. Health plans typically recredential and hospitals typically reappoint. And that time frame difference, we talked before, it's 3 years for the under NCQA. It's 2 years typically in a hospital environment. There are some differences if it's a DNV or CMS only facility, but typically everyone's following a 2-year cycle. And as we talked before, health plans are month year to month year. In the hospital environment, it's month day year to the day. Can't be 1 day over. It's month day year to month day year. And then that final approval process. Under health plans, it can be the credentialing committee or the designated medical director if the specific criteria are met as a clean file. And for the healthcare organization, it's the governing body making that final decision or its designated subcommittee. So I want to take this now and move into provider enrollment. That's the flip side of the coin. And understanding, again, what those payers are requiring can help an organization with their enrollment processes and to make them as efficient as possible. As we talked earlier, provider enrollment is not credentialing. I have worked with some organizations where they call it a credentialing process, and it's really a matter of understanding exactly what's involved with that process to make sure that we're talking about the same thing. So I stay away from calling it credentialing, although you are collecting a lot of the same information and it is supporting a credentialing process, but that is what the payers are performing. So I stick to the provider enrollment terminology. And provider enrollment, it can be a very challenging process for an organization because our healthcare environment is so much more complex these days. There's a lot, again, we talked a lot about the hospital-owned practices. We have clinically integrated networks. We have the ACOs in play. And all of those things can have an impact on the volume and the types of credentialing and the types of enrollment that has to occur. But understanding what your payers are requiring can really help you with your enrollment process to be as effective and as efficient as it can be. some of the differences, there's some differences between the kinds of payers and what they do and how they process. So if you're working with Medicare, CMS has a PAYCO system, Provider Enrollment Chain and Ownership System, another acronym, which allows you to submit the forms electronically for enrollment as well as for the revalidation process. Not everyone uses that process. Not every process is perfect, so some organizations still use a paper process. The payers, as I mentioned before, will primarily use the CAQH ProView system for their application data. So a lot of organizations are managing that information for their practitioners in the CAQH database. State Medicaid plans all have various requirements and processes. So if you're in multiple states, that can make a challenging process even more challenging, having to understand the different requirements under Medicaid. And then all of those organizations and all of the payers have unique participation requirements that you'll need to be aware of to make sure that what you're submitting is meeting those expectations. So what are some of those specific challenges with provider enrollment? Volume is a significant challenge because each practitioner can be participating in 10 to 20 or more payers. I worked with an organization that it was closer to 50 because they were in multiple states. So it was just a lot of organizations to manage a provider enrollment process for. And the forms, again, they can be different forms. You're filling out multiple forms. Some are paper, some are electronic. Again, CAQH has certainly helped with a lot of the payers accepting that form, so managing that data in CAQH, allowing the payers to collect it that way, has certainly afforded more efficiency in the process. And the requirements, each payer is going to have some unique requirements that you'll need to be aware of that can impact whether your application is complete or not. And the timeliness, this is what I hear the most, is the time it's taking payers to do their internal credentialing process after it's all been submitted. So payers, I've heard very positive comments that some payers, they're getting it done in 30 days. Others are taking more upwards to the 180 days, and I've even worked with someone who said it was taking a year. So it varies greatly, and depending on your payers and where you're receiving the majority of your revenue from, that can have a big impact. Even if you do have a payer on the low end, on the 30 to 45 day range, it's still a time that impacts your ability to receive revenue for the services that are being provided by your practitioners. And communication is a challenge because it's with provider enrollment and all of the different payers. A lot of times the payers communicate back directly to the practitioner and not to the provider enrollment team. So now you're circling back to the practitioner. Have you heard from the payer? And so it's a circular communication process that can be very challenging to make sure you have all the current information. And the revenue delays that we've mentioned before. Not getting the practitioner's credential timely into the networks delays enrollment, it delays receiving revenue, and there can be payments being written off or delayed, which significantly impacts the organization and the practitioner. So what solutions can we offer in this space to be more efficient, to have a more effective and more timely provider enrollment process? Allow 30 days. When you sign a contract with a practitioner, they sign it, they return it. Don't execute it right away. Give yourself some time to collect all the information that you need, to get everything ready, to start the credentialing and privileging process at the hospital if required. Just gives you that breathing room to buy some time before you would actually execute the contract. Require that when the contract comes back to you, that completed medical staff application for hospital privileging, that be returned as well. Maybe there's payer applications that you know you're going to need. Can those be completed as well? But try to get as much as you can up front so that there's not a delay within your own timeline. Sending the contract out, waiting for it to come back, and then sending out applications and then waiting for them to come back, that just delays the process. So see what you can combine up front. Know what each of your payers are requiring. Again, most of them are going to have a baseline set of requirements that are going to be very similar. If they're following NCQA, you now know what those requirements are. So just be aware of where they're different and track that information so that when you are submitting applications, you know exactly what additional information each payer is going to expect to receive to have a complete application to process. So that is allowing you to make sure that whatever is getting submitted to the payers is as complete, is as current and accurate as possible to allow them to start their process as quickly as possible. Consider starting the process sooner rather than later. Some organizations are looking at where they're collecting the information in the process. We'll talk a little bit more, but if you've got a lot of the same information is being needed by recruitment. It's being needed by the Medical Staff Services Department for hospital credentialing and privileging. It's needed by provider enrollment. So where can you streamline that process and have one area collect more of the information up front so that it can be used by others down the line in that total process? Look at your credentialing software. What kind of functionality does it offer you to achieve maximum efficiency? Pre-populating those applications, obtaining information and submitting it online. Anything you can use your technology to help your process is going to add benefit. And communication, that is such a critical component, and you can't, in my mind, you can't over communicate in this space. Internally within your own organization so that everyone knows what's going on with each practitioner that you're enrolling, when their effective dates are with each plan as you receive them so they know they can start seeing patients, and just communicating with the payers, with the practitioners, and everyone that's involved in your organization that's a key stakeholder in the process. Additionally, think about how you can integrate credentialing and enrollment within your organization. If you think about how the vast majority of the employed practitioners within a hospital or health system are already going to be credentialed. So there's some duplication there that can you take advantage of that and leverage that information that's already being collected, already being processed, and incorporate provider enrollment with your Medical Staff Services Department or your credentialing department. A lot of that information it can be used in multiple ways. And think also about recruitment because they need a lot of the same information up front as well when they're even considering offering a contract to a new practitioner. So we've seen organizations go into that level of integration as well. Again, to minimize the impact to the practitioner and to be able to utilize the information where you're overlapping between all those different areas because you're all needing information. You could all be using the same database and sharing that information in a very efficient way. And then the last element that we're going to get into in more detail is about seeking delegation with your payers. This can really have the most significant impact on reducing your turnaround time for network participation for your practitioners. Claims will be processed more timely and paid more timely because you're not waiting on the payers to do an additional credentialing process. So let's talk about delegation and what that means. So these are just definitions from the dictionary, from NCQA, but basically you are giving another entity the authority to do something that you would typically do. And the payers are going to vary in how much they delegate. Some payers are going to delegate a lot. Some will delegate very little, if any. So it's going to vary, and you should really be reaching out to your payers to understand what their requirements are for delegation and whether you would qualify. There's several steps involved with delegation that NCQA requires that a payer perform. They have to come in and look at your organization and look at your credentialing process to see if it meets their standards, their requirements. So they'll be looking at policies and procedures. under NCQA and under the payers, if it's not documented, you didn't do it. Even if it's in the file and you can show that you verified the license from the appropriate source, your policies and procedures have to define that. And then they will look at your files to confirm that you are doing what those policies and procedures say you do. And if you meet those requirements, then you would enter into a delegation agreement with the payer. And there are very specific elements that have to be included. NCQA has a list of things that need to be there. But basically, that agreement needs to define the roles and responsibilities between each party as it relates to credentialing and reporting of practitioner information. And once that agreement is in place, then every year NCQA requires an annual oversight audit, and it's basically the same thing as the pre-delegation assessment. It could be a little more streamlined depending on the use of technology and doing desktop audits, but the oversight has to occur at least annually to ensure that the organization's credentialing processes continue to be compliant and have changed if NCQA standards have changed, or if the payer has implemented some new requirements, that your policies and processes are now following those as well. So why do you want to delegate? From a payer perspective, there's a lot of reasons. It can reduce the turnaround time because they want those practitioners in their networks as well. They have members that want to see certain practitioners. So delegating alleviates some of the processing time on their end as well. And payers have a lot of practitioners that they have to credential. Depending on whether they're a state or a regional or national network, it can be thousands up to hundreds of thousands. So delegation can really help them manage that significant volume that they have to credential. So it impacts their resources, the staff they need to have, their budget, the time, and allows them to grow their networks in a more efficient manner. It also supports their contracting efforts. If there's a particular group that they need to support their network, delegation may be a way to secure that agreement. And their practitioners are more satisfied because, again, they're getting into those networks much faster. From the organization's perspective, the entity that's being delegated to by the payer, a lot of similar reasons to consider delegation. Again, it's going to reduce the turnaround time for your practitioners to get enrolled. And that's really the primary goal, is how to get that time frame down to as short as possible. Because you need that timely reimbursement. That impacts your organization if you're still waiting for the dollars to come in the door for services that you've already provided. Your resources that you currently use for provider enrollment will decrease depending on the terms of the agreement, but most often the payer wants to delegate the full process. So resources that are trying to manage a provider enrollment process can do other things that the organization needs, can support delegation with the reporting and the oversight audits. There are a lot of different ways to utilize those resources. And you're also going to have to keep in mind that there are some payers that aren't going to delegate, and they may be commercial payers. We know Medicare and Medicaid, Medicare and Medicaid don't delegate. So there's still going to be provider enrollment activities that have to be performed. But you will definitely see resources reducing or being reallocated to other activities. And if you integrate with your medical staff services, credentialing departments, then there's opportunities there as well, because you're not managing the same data more than once. Contracting leverage for the group as well. For those employed practitioners, if they're part of a medical group or a provider organization, and you're doing a very comprehensive, compliant, NCQA compliant credentialing process that the payers would like to have you do, then that gives you maybe a little leverage in those contracting negotiations. And ultimately, your employed practitioners that are being enrolled are much more satisfied because they are not encountering any of those delays. And there's certainly a lot less paperwork involved for them and everyone involved. There are some disadvantages. I mean, with every solution, there's going to be some challenges, but most often these can be easily overcome. On the payer side, some have a fear of that loss of control. They are giving over a very important process to another entity, and some are very reticent to do that because it can impact their accreditation survey results. If a delegate's file is not fully compliant and it gets pulled during their NCQA audit, NCQA will ding the payer for that. So a lot of them are concerned about that. And they still have to have resources to perform the oversight audits when they do delegate. So they still have those responsibilities. And for the delegated entity, you're going to have some additional responsibilities based on whatever that health plan requires. They may need additional practitioners credentialed. Not all practitioners that participate in the health plans may be going through a hospital credentialing process. So I've worked with some organizations where they've had to actually expand their scope a little bit and take on some additional work to credential, not necessarily through a medical staff process, but to do the application and the verifications for some practitioners that may only be working in a practice, an office practice that's not owned by the hospital, but they are part of a contract. Still have to have resources to support the oversight audit, so that's in addition to actually doing a credentialing process for all of these practitioners. And again, the enrollment processes are not fully eliminated. But overall, both parties, the benefits of delegation will typically outweigh these challenges, especially when you look at how it impacts the bottom line. Keys to achieving delegation success. From a payer side, it's so critical that they do their due diligence prior to delegating, and that's what that pre-assessment process is for, and then continuing to monitor and continuing to do that oversight on an annual basis and identify any potential issues early on so that they can be corrected and the delegated entity continue to be compliant. And having those agreements, those delegation agreements, clearly define the roles and responsibilities. Who is actually doing what? What are the responsibilities of the payer, and what is expected of the delegated entity? And communication, that's just key, back and forth, educating what the requirements are, if there are any changes in their policies, that kind of thing. For the delegated entity, just making sure that your policies and procedures are well documented, that they are compliant with the accrediting bodies that the payers follow, as well as any of those additional unique requirements. Understanding what the payers are responsible for, what they are, especially one of the things that I come across, it's not just NCQA sometimes. The state, if there's Medicaid, managed Medicaid plans involved, there may be some additional state requirements that go above and beyond. So understanding exactly what's involved for each payer and tracking that. And performing a timely credentialing and recredentialing process, and again, communicating. That's just critical on both sides of the coin here. And what are your results? A really more highly effective and integrated process as it relates to your practitioners and the onboarding. Just really, is your onboarding process as effectively integrated as it could be? If you look at all these processes on the left, your recruitment, your contracting, credentialing, enrollment, and orientation, they're all critical aspects to onboarding an employed practitioner. And they can all have a significant impact on the success of both the hospital and the health system, as well as the physician involved or the practitioner involved, and resulting in timely quality care for the patients. So having these areas fully integrated and working well together and communicating really has a significant and tremendous impact on the organization. So I just have a few questions I thought you should be asking yourself after the webinar today. Things to think about and take back with you. Is your provider enrollment really as efficient and timely as it can be? And if not, then can some of these tips throughout this webinar help you achieve that? Can your provider enrollment process be integrated with your medical staff services or credentialing process if you're in a hospital or health system to be even more efficient and increase your revenue stream through timelier reimbursement? And can you achieve delegation with your payers and really take it to that next level and have more integration and more timely reimbursement and faster enrollment with your payers? So that's what I have for you today. I've seen lots rolling in, so I'm going to turn it back over to Callie at this point.
All right, thank you so much, ma'am. We do have a couple questions that did come in. We may not be able to get to all of them today, so do not fear. We will reach back out to you individually after this webcast to help get your questions answered. I would like to remind everyone that you will be receiving download information in a separate email from communications@symplr.com that will have your download link and the ability to watch the archive. You will also receive your CE credit in a separate email from communications@symplr.com. So that is something else that will happen. If you would like to make sure that you get these and they're not eaten up by your firewall or your spam folder, please add communications@symplr.com to your email address book. First question that rolled in is, do hospitals need to be credentialed for payer enrollment?
Okay, I think the question is referencing the hospitalist, which is you know, the group of practitioners that work solely within that hospital and usually take on a lot of the admissions from the community-based family practitioners and internists that aren't typically admitting into the hospital anymore. And under NCQA, you would not typically see a hospitalist needing to be credentialed by a payer, although as an organization you may need to be part of an enrollment process to facilitate the billing process. You also have to look at hospitalists from the perspective, are they full-time hospitalists working in that organization? Meaning, again, payers typically wouldn't put them in a directory because a member isn't going to go, oh, I want to be seen by, you know, Dr. Smith hospitalist. They're going to see whoever happens to be working at the time they get admitted. But if they are a hospitalist part-time and maybe also have a private practice in their specialty, then that situation may require them to be credentialed by the payer and be enrolled as well.
All right, thank you so much, ma'am. Next question is, do all documents received by the provider need to be dated and or time-stamped of received?
That, you know, is something that we used to do a lot of, and I think it depends on your internal process. And I think technology has really limited the need to have a, you know, every piece of paper date stamped, because for one, a lot of information is now coming in electronically. The databases have those fields that allow you to document electronically, you know, when it came in or who received it, who verified it, that kind of thing. So depending on your process is really going to dictate. If you're still very paper driven, then you may need to have a way to document when you receive something and who verified it. It could be on the document itself. It could be on a checklist. NCQA specifically allows a lot of variation in that, as long as the key elements are documented in some way, shape, or form. You know, what date was the element verified? You know, who verified it? How was it verified? Those types of things. As long as it's documented, it can be managed in many different ways.
Okay, thank you, ma'am. Another one is, are clinic/group practices that are physician-owned required to follow the same steps as a hospital for appointments?
I'm thinking on that one. Are clinics that are physician-owned? That's a great question. It will depend. Is it an organization that is certified in any way? I know NCQA offers a provider organization credentialing certification, so under that scenario there would be a requirement for credentialing activities. A lot of it's really just going to depend on the structure of that organization and their bylaws and their policies on what they do. I'll have to think about that. If you can, if Callie, if you can have that individual's information, or I can maybe see if I can find some other details about that. But it is a little different, and there's a lot of, I think, factors that come into play onto whether or not you're required. It's just depending on your structure, your internal structure and requirements, as well as whether you're going through any kind of accreditation or certification process.
Not a problem. Ms. Lockhart, I will put you in connection with Ms. Amy after the webcast. We'll make sure that we get your question answered pending her finding out those couple of other things. It looks like we might be out of time. I'm going to do a quick commercial break, and then we'll have time for one more question. So Ms. Amy, if you could advance it one slide for me. symplr and Cactus provide you, or Cactus from symplr provide you with easy-to-use, effective solutions to manage the complete life cycle of your providers. We offer y'all solutions with provider credentialing, provider privileging, quality and performance improvement, peer review, along with the entire Cactus suite. If this sounds like something that would benefit your facility, please reach out to us at sales@symplr.com, and we would be more than willing to help y'all. All right, last question. Let's find it. Regarding malpractice claims history for health plans, does that mean that the plan has to primarily directly with the insurance company, or does an NPDB report suffice?
Under NCQA, they allow the use of an NPDB report to satisfy their requirement for verifying malpractice history. So some plans, payers may go to the malpractice carrier directly to verify that, but I think the vast majority are using that NPDB report, and you think the NPDB has been around for quite some time now, so you are getting a quite lengthy history of malpractice, which actually exceeds the requirements of NCQA. So that is where you are really typically going to see that verification that is through the NPDB.
All right, fantastic, ma'am. I believe that's all the time we have today. Is there anything you'd like to say in closing to our audience?
I just want to thank everyone again for joining us. I know that everyone is very busy, and I really appreciate you taking the time out of your day to join us. And again, feel free to contact me directly or through Callie at symplr. If you have any other questions, I'd be happy to help.
Yes, ma'am. Thank you all for joining us. We will be reaching out to everyone whose questions didn't get answered. If you think of any more, please reach out to us, and we are more than willing to help you. And please have a great rest of the day. Thank you all.
Thank you.